Good morning, everyone, and thank you, Dr. Vitull, for inviting me. And thanks, everyone. I'm going to give a talk on SGLT2 inhibitors in heart failure. Heart failure is a growing public health problem with high morbidity and mortality. You see the burden. Heart failure affects 64 million people worldwide. Heart failure is the #1 cause of hospitalization in people more than 65 years. Hospitalization for heart failure is projected to rise by 50% over the next 25 years. The 5-year mortality rate for patients with heart failure is around 50%, and mortality significantly increases after each heart failure readmission. This is the European Society of Cardiology diagnostic criteria for heart failure categories. HFrEF, as we say, HFMRF, MF, or HFpEF. HFrEF is a heart failure reduced ejection fraction. Sign and symptoms of heart failure and ejection fraction is less than 40%. HF, heart failure, mildly reduced ejection fraction. Sign and symptoms of heart failure and ejection fraction is between 41 to 49%, and then preserved ejection fraction, HFpEF. These are signs and symptoms of heart failure, ejection fraction more than 50%, and this should be some objective evidence of cardiac structure and or functional abnormalities consistent with the presence of LV diastolic dysfunction versus raised LV filling pressures, including raised natriuretic peptides. So what are the changes in LVF occur over time, and they are associated with specific patient characteristics, and that's very important to understand. HFrEF can go to heart failure, mildly reduced ejection fraction. It can recover. If you are treating a patient of reduced ejection fraction and you are recovering it to mildly reduced ejection fraction, and mildly reduced ejection fraction case can recover to preserved ejection fraction. And what is happening, patient of preserved ejection fraction can progress to mildly reduced can progress to reduced ejection fraction. So this way it can go here and there. What is factor associated with progression? That is the diabetes, ischemic heart disease, lack of specialized heart failure follow-up, and higher anti-pro-BNP levels. And factor associated with the recovery, they are the younger age, female, low heart failure severity, shorter heart failure duration, and fewer comorbidities. So that's very important. Some patients coming with this low ejection fraction, you can improve the patient. So many people, they ask you, can I improve? Definitely you can improve. So readmissions and mortality, they are common among all types of heart failure. And this graph is very important. Among all heart failure types, heart failure has the highest 30-day readmission rates compared to other diagnoses, and mortality significantly increases after each heart failure readmission. You see, these are the bar diagrams, heart failure readmissions, and all-cause readmissions and all-cause death. Whatever you are taking it, whether it's a HFrEF or HF mildly reduced or HFpEF, all these three criteria, you are finding readmission rates, all-cause readmissions, and all-cause death. They are almost near same. The prevalence of different types of heart failure is changing over time. Let's talk about 1985 to 94, and now we are talking about 2005 to 2014. What is happening in 1985 to 1994? You imagine there HFrEF was 44, it has reduced to 30% up till 2014. Or what has happened to preserved ejection fraction? It has increased more than 37%. So why it has increased? Why HF preserved ejection fraction prevalence has increased? This increasing life expectancy and the aging of the population. Global population is rapidly aging. The rate of HFpEF among patients with heart failure, they are increases with the age. Increase in comorbidities associated with the aging. Epidemic of cardiac and non-cardiac comorbidities. Improved survival after onset of CAD. The rate of atrial fibrillation increasing due to an aging general population and increased longevity. Increasing incidence of obesity, metabolic syndrome and the diabetes. Increased clinical recognition, improved diagnostic techniques and development of diagnostic guidelines. This is the major, there are many reasons, why this preserved ejection fraction over the years, it has raised more than 37%. And there are the many reasons what I have really elucidated here. Each hospitalization will bring the patient to closer to the death, and that's very important to understand. You imagine this is the structural heart disease. What is stage A, stage B, stage C and stage D? We know this is the classification of the heart failure. Stage A, you know, it's a structural heart disease at high risk, but without structural heart disease or symptom. This is stage A. What is the stage B? It's a structural heart disease but without sign and symptoms. Stage C, structural heart disease with prior or the current symptom, and stage D is a refractory heart failure requiring specialized intervention. And here in this graph, this is very important. Progression of the remodeling. You are reaching at the stage D refractory heart failure, and every hospitalization brings the patient to closer to the death. So despite poor prognosis, there is a lack of urgency for early identification and initiation of GDMT. What is GDMT? It's a guideline directed medical therapy. Over 40% they have heart failure symptoms up to 5 years prior to the diagnosis. That's very important. The people, they are living with the heart failure but they are not diagnosed. 75% they are diagnosed with heart failure following an unplanned hospitalization for heart failure. Guideline directed medical treatment for heart failure is suboptimal for the majority of the patients, and over 30% of mortality rate 1 year after hospitalization for heart failure. So what are the goals of pharmacotherapy for patients with heart failure? One is what you want: reduction in mortality, prevention of recurrent hospitalization due to worsening heart failure, improvement in clinical status, functional capacity and quality of life. What do the guidelines recommend? American European Society of Cardiology 2021 Heart Failure Guidelines. Dapagliflozin recommended as one of the cornerstone therapies for HFrEF. Well, how to management of the patient with the HFrEF reduced ejection fraction. Start with the ACE or ARNI, beta blockers, MRA, and DAPA or the empagliflozin, then loop diuretics for the fluid retention. These are the class 1 indications. Then this is definitely the LVF is less than 35% and QRS is less than 130 milliseconds, and where appropriate you can put non-ischemic ICD or ischemic class 1 indications. If LVF is more than 35%, device therapy not indicated or appropriate, or if symptom persist, consider therapies with class 2 recommendations. If the patient is in sinus rhythm and LVF is less than 35% and QRS is more than 130 milliseconds, you know then the procedure CRTD or the P. So this is a very important algorithm to understand, and these are very strong heart failure guidelines to understand. Then 2022 AHA or ACC or Heart Failure Society Association Heart Failure Guidelines. SGLT2 inhibitors recommended the class 1A for HFrEF cases. Step 1 therapies may be started simultaneously or without specific medication sequence, should not be delayed. Step 1. Establish diagnosis of HFrEF, address congestion, initiate GDMT. Patient with HFrEF and LVF less than 40% stage C, start with these 4 things: SGLT2 inhibitors, beta blockers, MRA, ARNI, ACE or ARB. And this is the 1A indication. In patients with symptomatic chronic HFrEF, SGLT2 inhibitors, they are recommended to reduce hospitalization for heart failure and cardiovascular mortality, irrespective of presence of the type 2 diabetes. That's very important, class 1A indications. And these 4 drugs you have to add in any case of HFrEF, and that's a really important step 1. This is ACC now 2023 guidelines, treatment algorithm for GDMT in HF, preserved ejection fraction. What I am telling in the previous slide, it was in the reduced ejection fraction. What was in the preserved ejection fraction? SGLT2 inhibitors. They are really indicated now in the preserved ejection fraction. And down you see, for individuals with the fluid retention, NYHA class 2 to class 4, titrate loop diuretics. Then for women, all ejection fraction, and men with the ejection fraction 55, less than 55 to 60%, fluid retention, and MRA. For women, all ejection fraction, men with LVF 55 to 60, add ARNI. And for ARNI eligible individuals who cannot take due to cost or intolerance, add ARB. So this algorithm has become very important, because we have a lot of algorithms as the treatment for the HFrEF for the mildly reduced ejection fraction, but for the HFpEF, there was always a question, what the treatment you need for HFpEF cases. But now 2023 ACC guidelines, they say SGLT2 in these inhibitors, they have become a very important part of the treatment for the HFpEF. We will be coming for a few of the slides for the HFpEF treatment, how SGLT2 inhibitor dapagliflozin has become important. What is the evidence with dapagliflozin to support guideline recommendation in the heart failure management? There are the recent positive trials in the HFrEF. DAPA could show reduction in all CV endpoints on top of this SOCs. There are various trials like SHIFT trial. Already we know with the ivabradine paradigm HF trial in which we have seen the sacubitril, enalapril versus Sacwell, and DAPA HF trial in front of us. All these three trials, you see DAPA HF trial in which dapagliflozin versus placebo. You see the benefits when we see CV death or heart failure hospitalization, heart failure hospital versus HHF, and then CV death and all cause death. You see the p-values. Here, just wait. You see 0.75, 0.70, 0.82 and 0.83. Comparatively to all the previous two studies, these hazard ratio, they are really fantastic. So this has shown how the DAPA is really fantastic as comparison to the previous two trials, paradigm trial and the SHIFT trial. So DAPA could show much reduction in the all CV endpoints on the top of all this. DAPA HF, the first and the only SGLT2 inhibitor to significantly reduce CV mortality in HFrEF patients with and without type 2 diabetes. This contains 4,744 patients. It includes LVF less than 40%, elevated anti-pro-BNP, EGFR more than 30, and 1:1 randomization on the one arm DAPA, 10 mg on the another arm placebo. Primary endpoints is the composite of CV death or worsening of the heart failure, hospitalization for heart failure or urgent heart failure visit. And we have taken the secondary endpoints like CV death or HHF, hospitalization for heart failure. Total number of HHF, changes in this scoring, more than 50% sustained decline in EGFR, all-cause mortality. 1437, this is anti-pro-BNP baseline characteristics, 31% average LVF, 55% they were without diabetes, and 41% with an EGFR less than 60. So this was a good study in which there were 55% people they were without diabetes. So DAPA significantly reduced the risk of CV death and worsening heart failure in patients with HFrEF cases. You imagine this is the study which is very significantly in which the rejection fraction was low and DAPA has been used. And here the both diabetic and the non-diabetic population that has been used. And you imagine CV death or worsening heart failure has 26% relative risk reduction, 18% CV death and 30% worsening heart failure. Consistent benefit in the primary endpoints across key subgroups. All-cause mortality was also reduced in the DAPA group, 17% relative risk reduction. And this number is not small, it's a very, very big number when you talk about in the cardiovascular worsening or death or worsening heart failure. No study in the previously any which has shown such like fantastic number. This is the effect of treatment modalities, alone or in combination on CV mortality or hospitalization for heart failure in HFrEF. And the 4-pillar strategy has the lowest hazard ratio. What are the 4 pillars? They are ARNI, beta blockers, MRA and SGLT2. MRA is like spironolactone or eplerenone. These are the 2 drugs in MRA we are using. Now you can see the red bar. You imagine ARNI plus beta blocker plus MRA plus SGLT2. These 4 drugs, they were when used in any case of HFrEF. You see the hazard ratio was 0.36. 63% benefit it has been seen when these 4 drugs they were added in any case of HFrEF. And you imagine the down ARNI plus beta blocker plus MRA plus Versiquad, ARNI plus beta blocker plus MRA plus omecamtiv. All these or other combinations, they never stand out. What we have seen, this 4 drug combination. This is GDMP, what we are saying. Any case of HFrEF coming to you, you have to add these 4 drugs. And the question arises, in how much time you want to add these 4 drugs? I am saying the all guidelines, they say over a span of 4 weeks. You have to add these 4 drugs. Add one by one. I don't say in a one day you are going to add these 4 drugs. Any case of HFrEF, less than 40%, coming to your clinic, in your OPD, in your IPD, start with the one thing. The first is start with the beta blocker. Start with ARNI. Start with MRA. Start with the SGLT2. Add these 4 drugs. You have to add it. You see the benefit. Hazard ratio 0.36. How much benefit you are going to give to your patient? 63%. That's a very big benefit. Benefit on what? CV mortality. Hospitalization for heart failure is one of the biggest benefit which we have never seen in our life, whatever the studies in front of us. So new breakthrough in the management of heart failure with LVF 40% now. So this is a summary of this heart failure, mildly reduced ejection fraction and the heart failure with the preserved ejection fraction trials. None of them were positive trials. Paragon HF, TopCat trial, iPreserve, PEP-CHF and CHARM Preserve trial. All these trials, p-values, just see, focus on the p-values. 0.06, 0.14, 0.35, 0.55, 0.05, insignificant. No trial could say that any significant benefit. Primary endpoint, CV death, hospitalization for heart failure. We have not found with all these drugs, we could not find in HFpEF, in preserved ejection fraction or mildly reduced ejection fraction. What does it mean? When the ejection fraction is more than 40%, we are not finding any benefit of these drugs. We are finding Saquel is RB is very good drug when the ejection fraction is less than 40%. We are finding less than 35% benefit of spironolactone, much benefit. But when the ejection fraction is more than 40%, preserved ejection fraction, we are not finding benefit. Then what to do? Where we are? What to do in these cases who are having a more than 40% ejection fraction? Deliver. That is a trial now, which has come. Dapagliflozin evaluation to improve the lives of the patient with preserved ejection fraction heart failure. This is the trial which has shown. It contains around 6,000 patients, more than 40 years of the age with or without diabetes. The beauty of this trial was this, that it contains both patients, diabetics and non-diabetics. And here the ejection fraction was more than 40% and evidence of structural heart disease within 12 months. Symptomatic NYHA class 2 to 4 heart failure at enrollment, elevated anti-pro-BNP levels, EGFR more than 25, ambulatory or hospitalized off IV heart failure therapy for more than 24 hours. 2 groups, one arm is DAPA-10, another is a placebo, and you see the visits over around 2 to 3 years median follow-up time. Very good study. Primary endpoints, what we want to see in this study? Time to first occurrence of any components of the composite of CV death or worsening heart failure event, hospitalization for heart failure or urgent heart failure visit. Secondary endpoints, we want to see total number of heart failure events, change from baseline in some scoring, time to occurrence of CV death, time to occurrence of death from any cause. So let's see, what is it? There were 353 sites, 20 countries, and already randomization as I told you, and mean age was 72 years, 44% women, 75% NYHA class 2, 25% NYHA class 3, moderate symptomatic impairment, elevated anti-pro BNP around 1000. It has to be more than 1000 when you take up any patient with the anti-pro-BNP levels. 16% enrolled or more less than 90 days of hospitalization. High rate of comorbidities. Imagine 45% they were diabetics, 45% BMI more than 30, they were really obese, 89% hypertensive, 57% history of atrial fibrillation, 51% coronary artery disease, 61 ml is the EGFR mean. Well represented LVF groups. Now that is the most important to see. 36% they were 50 to 59% they are having ejection fraction, well preserved. So you imagine what is the primary composite of CV death, hospitalization for heart failure, urgent heart failure visit. 18% relative risk reduction. I am talking about a study in which ejection fraction is well preserved. Before this trial, we don't have any drug for the preserved ejection fraction. Now, this trial which has told us that dapagliflozin has worked wonder in this trial, this DELIVER trial. 18% relative risk reduction of CV death, hospitalization for heart failure or urgent heart failure visit. You imagine, and what is the significant? Statistically, we start even early as 13-day benefit. You have started with this. Consistent treatment benefit across all pre-specified subgroups. You imagine whether it's a diabetic or non-diabetic, you are finding benefit. Whether ejection fraction is 49, 50 to 59 or more than 60, you are getting benefit. Whether prior LVF is less than 40 and now it is improved to more than 40, yes, it is benefiting. So imagine in every group, the DAPA is really getting benefit in this study. CFT outcome, no adverse events were seen, absolutely same between as comparison to the placebo. So evidence of DAPA across the full ejection fraction using pooled analysis of DAPA, heart failure and the DAPA-HF trial and the DELIVER. These two trials, DAPA-HF trial is trial in which HF-REF cases they have been taken, and DELIVER trial in which ejection fraction more than 40% has been taken. You imagine we are taking the pooled analysis design. And you can imagine this pooled analysis design, DAPA-HF on the another one side and DELIVER trial in which the preserved ejection fraction has been taken on the other side. You imagine 14% relative risk reduction, CV death, all cause death, 10% relative risk reduction, hospitalization for heart failure 29%, 26%, MACE 10%. You imagine this is a fantastic reduction. And effect was consistent across a full range of LVF. DELIVER extends the benefit of DAPA across the range of ejection fraction as I told you in the 3 slides before. What DELIVER adds to the HPF, HFpEF management compared to other SGLT2? Now here the question arises, what about empagliflozin, another SGLT2 inhibitors? We have to compare. Why we are talking only about the dapagliflozin? We are having 2 trials with the empagliflozin also, EMPEROR reduced and EMPEROR preserved. Why we are not talking about the EMPEROR? Empagliflozin EMPEROR preserved had attenuation of benefits in patients with LVF more than 60%. Here you can imagine in EMPEROR preserved trial the ejection fraction went more than 60%. You see the unity line hazard ratio 1.07. It was not showing benefit. You see the unity line, you see the round, it is crossing the unity line and the hazard ratio is 1.07. So EMPEROR preserved trial, it never showed any much benefit when the ejection fraction was more than 60%. But in the DELIVER trial, the dapagliflozin and all the ejection fraction has shown the benefits. DAPA has shown clinical benefit in primary endpoint irrespective of the ejection fraction, even at more than 60%. This is there. You see the unity line and all the 3 squares they are on the one side of that, on the favoring side of this dapagliflozin. You imagine this is there. The first disease modifying therapies across the LVF spectrum. Heart failure with improved ejection fraction. There is another entity which is called heart failure improved ejection fraction. So what is improved? Initial classification is reduced ejection fraction less than 40%. Reduced ejection fraction, improved ejection fraction is more than 40%. Recognizing LVF is dynamic. The AHA or ACC guidelines, they define improved ejection fraction as previous LVF is less than 40% and a follow-up measurement of LVF more than 40% as defined in the delivered trial. Like some patient is less than 40%, you are treating this patient by GDMT and now the patient is more than 40%. They say you can use this term that now this patient is having heart failure, improved ejection fraction. So then they say in patient with heart failure, improved ejection fraction after treatment, guideline directed medical therapy should be continued to prevent relapse of the heart failure and LV dysfunction. Even in patients who may become asymptomatic, even the patient is improving, but never stop the treatment and continue with the same treatment as it is going on in the HFrEF. So heart failure with improved ejection fraction in deliver trial we have seen because the patients are more than 40. We are having a group of the patients who are initially were less than 40 and now they are more than 40. So here you can imagine effect of DAPA was consistent in patients with and without prior LVF less than 40%, and you can imagine primary outcome, hazard ratio 0.74, 26% benefit, worsening heart failure even 16% benefit, all cause death 12% benefit, cardiovascular death 38% benefit. So in those cases in which there is an improved ejection fraction, in delivered trial dapagliflozin was really beneficial. So no benefit in CV death with empagliflozin even in pooled analysis. Another SGLT2 inhibitor as we talked about, Emperor reduced or Emperor reduced trial less than 40% or Emperor reduced more than 40%. We have time to CV that the hazard ratio is very 0.92 and 0.91. We are not finding much benefit. So mortality was significant in DAPA-HF and delivered pooled analysis covering entire spectrum. CV that 14% relative risk reduction we have found CV that in these two trials. So SGLT2 one dose, no titration in heart failure care across ejection fraction spectrum is one of my last slides. One pill once per day with no dose titration substantially improves survival and prevents hospitalization, meaningfully improves quality of life and functional status, benefits appear rapidly within days to few weeks of initiation, exceptionally well tolerated and safe, does not lower blood pressure or does so very minimally, no adverse renal effects, instead preserves kidney function and prevents dialysis. Largest and broadest trial to date in patients with LVF more than 40%. Enrolled patients were well treated with a high incidence of comorbidity in this delivered trial. DAPA provided a significant reduction in the primary composite endpoint, 18% relative risk reduction in CV death or worsening heart failure, consistent effect regardless of type 2 diabetes status, baseline LVF, enrollment during or within 30 days of hospitalization heart failure or not, and prior LVF less than 40 or not. Safety and tolerability consistent with the well-established profile of DAPA. Deliver and DAPA-HF demonstrated significant benefits of DAPA in heart failure regardless of LVF. Pooled analysis of DAPA-HF and delivered trials demonstrated consistent effects across LVF with a significant 14% relative risk reduction in CV death. I think this is my last slide, and thank you very much for kind listening. All right.
Thank you, Dr. Rohit Kapoor. Very nice presentation. I think in broadly, you see, the message is heart failure, whether it is reduced or whether it is preserved, I think SGL2 probably has the role to play in both the cases. I mean, like people, you see, I'm a physician.
You keep your mic close to your mouth.
Right, like I'm a physician, you see, most of the time, you see, the people sitting in the rural areas, they may not have the facilities for echocardiography, and the patient comes with heart failure. Probably, I think you recommend that the SGL2 should be the part of the treatment for heart failure. Is that right?
Pardon?
I think recommending SGL2 in any form of heart failure and sitting in a rural area probably is the right thing to do.
You don't have echo over there?
Yeah.
Without echo?
That's right.
If you have a symptoms of heart failure?
Yeah.
And you can add it. From my side, yes. Yeah, you don't have echo and the patient is a classical symptom of heart failure and you are pretty sure the patient has in heart failure, and all symptoms they pertain to heart failure. You got only X-ray chest. There is a classical cardiomegaly. Patient is rare in pulmonary edema. You say the patient is in heart failure. Definitely, you want to add it. You are allowed to add it. Dapagliflozin. Definitely, I will say yes. But over the time, I would advise you the patient should go for echo. Yeah, that's very important, because underlying what is the structure of heart disease, you have to see by echo. You should know what is the underlying reason why this is there. Because unless and until we know the etiology of heart disease, that is very, very important. But clinical diagnosis, if you are pretty sure the patient is in heart failure and the whole symptomatology pertains to heart failure, I agree with you. You can start with this all decongestant therapy along with all GDMT heart failure treatment. Yes, Dr. Shiva, what do you want to say?
No, I said that in villages at least an ECG can be done, and there are subtle features.
Keep your mic close to your mouth.
Is it? Yeah, this is better. So I said that a simple ECG can be of great help. ECG can give you and suggest some features of LV dysfunction. If a QRS is vital.
But sometimes ECG can be normal even. Because
yes,
that can show
surely, sir. That can be normal, but can help. So
X-ray can be a very good thing, because to see some edema and hyla prominent and bronchosvacular markings, they are very high, and you say this man is in pulmonary edema. I mean, and there is some cardiomegaly, you measure with the scale and you say, yes, definitely there is cardiomegaly.
Definitely, sir. Because you have seen the times when people were probably managed with X-rays and everything. I would like to congratulate you, sir, for a very lucid talk in SGLT2. I do not have many questions, but two things maybe from your clinical practice. I would like your comments. One thing again which is very dear to my heart, I always talk of women in heart disease. There was a meta-analysis published this year only on SGLT2s, where they found that the results that SGLT2 inhibitors gave in women were probably not as good as they were for men. Well, the results that were discussed in that population for women was that women behave in a very different way, and their adaptability is different once they have a myocardial infarction or coronary event. The adaptability of myocardium is different, so probably SGLT2s did not give that result. They also believed that comorbidities were more in women, like diabetes, hypertension and obesity. And of course, the endothelium, the fibrosis, the diastolic dysfunction, the stiffness of a woman's heart was different. So the response by SGLT2s was not as great. So this was a meta-analysis which was published this year, but again they had their own fallacies that women were underrepresented in trials, and probably most of the trials were not representing them well enough to be able to come down to these results. And the second comment...
You're talking about Asian women?
All the women. They took a meta-analysis of all the trials that included Emperor, Preserve.
Global study?
Yes, I'll share that meta-analysis with you. That carries Deliver, DEPA-HF, Emperor, Preserve. They include all, and this was published in American Journal of Cardiology.
Okay.
And the second thing is your comments. We always talk about there has been enough debate, and it is now believed that SGLT2 inhibitors are the first-line drugs which can be started. But when it comes to real-world practice, I'm not really sure how many of us are starting it as a first-line
therapy
in heart failure, sir.
In heart failure.
So so if you have a patient and you have to start one of the two drugs, we have issues of postural hypotension which arise with SGLT2 inhibitors, and when we have to give ARNIs. So what do you believe? Do you think we should go with SGLT2 first or ARNI first? So data is now favoring SGLT2, but what is your comment on that?
Most of the times, basically, when we say the...
I feel strongly, probably add-on therapy probably much more effective than they should start with the primary treatment with SGLT2.
Pardon?
Rather than starting SGLT2 as a primary treatment, probably add-on therapy will be the right choice.
Which therapy?
The SGLT2 therapy, we're using add-on therapy in heart failure, probably the right choice rather than the first choice, primary choice.
No. I tell you basically, these four drugs, they are very important in heart failure as a GDMT. Beta blockers, ARNI, MRA and SGLT2. Most of the guidelines, they say the first is not SGLT2. First is not SGLT2. I tell you frankly. Many times we have discussed in more than 50 CMAs, and many times the guidelines they say the first is still the most important is beta blockers. They are still number one to add. First is. Second number is RNA is second number. Third number is MRA. Then fourth number is SGLT2. This should be the sequence of events. But I tell you frankly, this sequence of events is not like a cement. It's not like a cement. Cement means it's not fixed. You can change this sequence of events according to your wish, according to your will. The thing is this, but SGLT2 never is number one. In heart failures, your first choice will be controlling tachycardia. My choice. First choice will be to add RNA and beta blockers always first, not SGLT2, frankly. So first choice will be either beta or RNA. You can do here, there, beta or RNA. Second, MRA is very important if the patient LVF is less than 35%, because it's really very important. If you go for some studies, Dr. Shiva knows a lot of studies about MRA benefits. Forehead. SGLT2 has a lot of benefits, but adding SGLT2 in any case of heart failure or any patient, you have to assess 15 parameters before adding SGLT2 inhibitor to any patient. Volume depletions, GTIs, infections, many things to see when you're going to start SGLT2 inhibitor in any of my patient. I have a checklist of 15 things before adding SGLT2 inhibitor. How much dose of diuretics? What is the dose of hypertensive drugs? What is the blood pressure? What is the postural hypotension? How is the patient standing BP? How is the patient moving about? What is the lifestyle of the patient? What is the diet of the patient? How much salt intake it is? I mean this much 15 parameters before starting SGLT2 inhibitor. That's why whenever I deliver a lecture and this question always comes to me, this is my on heart failure maybe more than 60th lecture of me, 60th. And this question always comes, what is the sequence of event, Dr. Kapoor sir, please tell me. I say SGLT2 is my fourth step, because deciding SGLT2 is tedious for me. So that's why I am keeping the fourth number SGLT2. First is always my beta in RNA. You add spironolactone or eplerenone depending upon what is the cost, patient is affordable. Fourth is SGLT2, but I have to add it. The thing is, are you going to add it? I have to add it. I am like a judge, like says, I have to add it. In how much time you are going to add it? I have a time of 4 weeks. Yes, over a span of 4 weeks, you have to add these 4 drugs. In any case of heart failure, you have to add it. यदि आपने ऐड नहीं किया, you will be punished. बात खत्म. आपको सजा मिलेगी. जिसने हार्ट फेलियर ट्रीट करना और उसने 4 दवाइयाँ नहीं डाली, तो समझो आपको सजा मिलेगी. बात खत्म. पनिशमेंट होगी. ठीक है डॉक्टर शिवा? यस, बिल्कुल. ये जज है हमारे सामने बैठे हुए. सो सजा मिलेगी. जिसने हार्ट फेलियर ट्रीट करना है, 4 दवाइयाँ डालनी है, 4 हफ्ते का टाइम है, जैसे मर्जी डालो, तो डालना पड़ेगा. सो ये बात है.
See, I can understand as if you are a diabetic, it's okay. If you are non-diabetic, probably it becomes a little difficult. You have to think 2 times before starting or adding.
No. Never think. Never think. Even in non-diabetic population, add SGLT2 inhibitor, khul ke dalo. Don't bother about non-diabetic population. You are not to think of non-diabetics. Khul ke dalo. Koi hypoglycemia nahi hone wala. Dapagliflozin does not cause hypoglycemia. It is a non-insulin tropic drug. A non-insulin tropic drug. It does not affect on beta cells. No लेना देना नहीं है इंसुलिन के साथ. आराम से खा लो. आपको डायबिटीज नहीं, आप मुंह में डाल लो, कुछ नहीं होने वाला. आराम से खाओ. नॉन डायबिटीज को खुल के डालो. कुछ नहीं होने वाला.
This was for my younger generation to know that, you see, they are so important, you see.
Yeah, so DAPA-HF trial, DAPA-CKD trials, DELIVER trials, they all contain 50% of non-diabetic population. So nothing to worry. आराम से non-diabetes को डालो, कुछ नहीं होने वाला. Non-insulin tropic drugs, nothing to worry. No hypoglycemia has not seen in any of these trials. Nothing to worry.
Thank you very much.
So actually,
Sure.
In real world practice, we face so much. We face pressures of 90-60, 96-60, 160 when patients of heart failure. Of late, what I have realized in my clinical practice is that I've been able to use, in the patients where I wasn't able to use these drugs to the guideline directed doses and targets, Versiguat has somewhere started getting a place in my prescriptions. So this is when I find that the patient fell down, had pre-syncopal symptoms, stopped, patient had hyperkalemia, stopped. And in fact, one of the slides of meta-analysis which you showed, beta blockers plus Versiguat, especially after the Victoria trial, we know that this is another drug in our armamentarium.
Yeah.
So when the BP is so borderline and patient is having renal failure, patient is having hyperkalemia, Versiguat 2.5 milligrams, patients are tolerating. Step it up after 2 to 3 weeks. At least you're able to render something to give them morbidity and mortality benefit. So this is a new thing in our armamentarium when we are not able to use what we actually at least we have something that we can give. There were times, when patients pressure 80-60, cardiomyopathy, LV dysfunction, you're not able to use. At least you have something in your hand to offer them. This is what I.
Definitely, but 90 BP is too much for us.
Yeah. Actually, more than blood pressure, very
even
right,
sir. Even 90 BP बहुत है.
Blood pressure से
90 BP बहुत है हमारे लिए.
Patient को symptoms हो रहे हैं, patient is cold, patient is clammy, the output is falling, the renal functions are deteriorating. The beauty of this drug Versiguat is that you can also administer it at a GFR up till 15 UC. इससे पहले even with ARNIs and all the GFR.
How much you have experience
30 is.
How much you have experience of Versiguat?
Versiguat, I do not know. I don't have the data to quote that. I'm just talking of my real world practice in the last 3 to 4 months only, I would say.
Right.
But then I'm able to give something, and I have a feeling that I have got evidence-based medicine to give me a reduction in all the, MACE events in these patients.
Keeping it only for the refractory heart failure, Versiguat. In the guidelines?
Well, guidelines have actually recommended that if a patient has needed hospitalization in recent past, or in our country, even if the patient has not been hospitalized but needed an injectable diuretic, IV Lasix, in recent past, because so many of our patients would not get hospitalized, we can kind of use these drugs. Of course, it is not class 1 indication as the 4 drugs that we are talking. But I'm talking of a situation when we are not able to use these drugs in our patients. I think everybody would agree. Of course, it's not just the pressure that we monitor. If the patient is warm and the patient is tolerating, we would like to continue these drugs. But there are many a times, sir, you would agree with me that when we have to diurize these patients, they become cold, they fall down, they come with those symptoms. So the beautiful drug, even the GFR, up till 15 GFR, you can give this benefit to your patients.
Definitely, it's very good comments of yours. Thank you very much for these comments. Versiguat.
Thank you, Doctor.
Thank you very much. Any more comments? Thank you.
Thank you, sir.